Our next speaker is Dr. Muhammed Walji. Dr. Walji received his PhD from UTHealth in Houston. He's the Associate Dean for Technology Services at UTHealth of Houston. He is a principal investigator on two NIH NIDCR funded studies, one is developing a patient safety system for dentistry. The second is implementing dental quality measures in practice. He also serves as a PI on other studies as well, including measuring occurrence of and disparities in dental clinic adverse events. And he's going to talk a little bit today about the BigMouth Dental Data Repository, which he developed and is overseeing at this time. So please join me in welcoming Dr. Muhammed Walji.
Okay, good morning everybody, and thank you Dr. Capelli for the very kind invitation to speak today. Let me get these fired up. Okay, so it's really my pleasure to talk a little bit today about BigMouth. How many are you familiar with BigMouth? Okay, so some of you. So BigMouth wasn't actually developed by me. It's been developed by a whole host of people, mainly at 4 different institutions, UTHealth being one of them, UTHealth at Houston. We also have UCSF, School of Dentistry, Harvard, School of Dental Medicine, and then Tufts, School of Dental Medicine as well. Four sites had got together, I think back in 2009, where we were very fortunate to get some funding from the National Library of Medicine through a GO8 resource grant, where we proposed this multi-institutional data repository. And so that's kind of been the foundation of some of the work that we've been doing in this field. So what I want to do today is to give you a quick demo of BigMouth. I'm hoping the technology will work. So this will be a live demo. This is how a user can actually access BigMouth. Because one of the things that when we proposed the project to the National Library of Medicine is what we said was, this shouldn't be just a data repository that only technical users can kind of get access to. We wanted all users to be able to, kind of peek into the data and start exploring for their research projects. The second thing we worked pretty hard on was this issue of data governance. So, it's relatively straightforward if you're one institution and you're trying to mine your data for various purposes. But if you are, more than one, you're working across states, all these competitive issues that we have, it becomes a little bit challenging. So we set up a data governance kind of process, and I'll go through that framework. Third topic I want to touch on is data standardization. There was a question earlier about diagnostic terminology, and we haven't had one in dentistry, and there's competing ones. I do want to talk a little bit about that because I think we've actually solved the problem. I think now there is actually one diagnostic terminology that we can all use, and I'm hoping to talk a little bit about that. Fourth is I want to give some examples of research projects. Obviously this is about dental public health, and many of our researchers are actually using BigMouth for dental public health projects, and many of those researchers are actually residents because they need to complete their theses as part of their various residency programs, and so I'll touch on some of them. And then lastly, we had a comment earlier by Captain Dye about a lot of the work is being done in data, right? And data is nice, but it's not actually information. And it's not that useful in its own. So I want to talk about how we're moving, stuff that we had in BigMouth in terms of data to actually information when it comes to looking at the quality of dental care as well. So that's kind of the framework. So right now we actually have 6 dental schools contributing. In addition to UT Houston, Harvard, UCSF, Tufts, we also have University of Pittsburgh and University of Michigan that are contributing to the database. And now this is open, and so if any other institution wants to contribute, they are able to do that. And we actually have one more in the pipeline right now that have gone through the process, University of Louisville, so we're hoping to incorporate their data to be our 7th site very soon. And one of my missions is to have Gary Guest and UT San Antonio actually contribute, and he's been promising me this for over a year. So hopefully by the end of the talk I may be able to convince him that we might want to do this. So the way this works is it's a centralized data repository. So we have all the data in one place. So all of the sites actually send their data to UTHealth at Houston, and we host it over there. Now this is a little bit different from some of the other data repositories that are more federated, meaning that each of the local sites has control of their data, and there's kind of some layer in the middle that goes out and kind of searches that data in a federated fashion. Now what we did was we proposed to just start simple. For various reasons, federated search is definitely a much more scalable way, but it's much more challenging in terms of implementation and perhaps maintenance as well. So we've kept it simple, but that doesn't mean that BigMouth can only be a centralized data repository. In the future, obviously, it can be moved to a federated platform. The second issue is, obviously, we wanted to have non-technical users be able to query BigMouth, and then, here we've listed some of the data that are available. And much of the data are structured data. So the good thing is many of our electronic health records, although the clinicians probably don't like it, they have to keep clicking and picking these things from pick lists. That's good from a research perspective, especially if it's accurate, because that makes it a little bit easier for us to mine as opposed to unstructured data. Now, one of the things that we're doing here that's a little bit unique is we're not collecting fully de-identified data. We're actually collecting what's called a limited data set. And that is where you've removed all of the identifiers for PHI, there's 18 identifiers, with the exception of dates, like date of birth, treatment dates, and 5-digit zip codes. And so we're actually able to do that under what's called the limited data set. And we don't have to consent patients beforehand to do that if we're using it just for research purposes. So that is an advantage in this process. So basically people submit their data, we provide them with the extract scripts, they run it against their EHR. All of these sites use Axiom, so they use the same similar data extraction scripts, and then they upload it to us on a secure platform, and then we load that data into BigMouth, and we do that twice a year. And so we've got the process down now. So we all know about electronic health records. We heard before about nearly 80% adoption in medicine. I don't know if we're that high in dentistry in terms of private practice, but we're certainly there when it comes to dental schools. Most dental schools have some sort of electronic health record, and many of them use the same exact one, which is Axiom, which is the one that we're focused on. Some of the challenges are, some of the data that's very useful is unstructured. It's in the clinical notes. It's in that narrative. It's the story that's being told by the dental team or the dental providers about the patient, and that's harder to mine. And also, obviously, what we're doing is we're using the data for secondary use. The primary use are treatment, payment, and operations to keep the clinics running. And so it's not intended for research. And this is where we get this tension between the research community, who want to have very nicely curated data sets, while what we have is a lot messier in terms of electronic health records. So the tension that we're trying to resolve is, can we actually make these data useful to actually conduct high quality research? And we hope we can. And then lastly, this issue of limited standardization, and I'll touch on this idea of, we do actually have a diagnostic terminology. So these are the data that we have in Axiom. Obviously patients' demographics, their treatments, we have diagnoses, because many of the schools that are in BigMouth actually collect diagnosis information with every procedure that's being built out. We have the medical history, the medical information, we have lots of medication data, we have information from the tooth chart or the odontogram, we have information from the perio chart. What I've learned is that the periodontists seem to be some of our main users of BigMouth, and they love to get into the details of all the stuff that's collected in the perio chart. And then we've got information about the provider. So obviously most of the data we have is from educational settings. So we have lots of information on what students and residents are actually doing. We don't have in BigMouth financial or billing information, but we do have insurance data. It's kind of a proxy if you're looking at socioeconomic status and things like that. Okay, so benefits of using EHR data. There's a really nice paper by my Song and colleagues, reusing electronic patient data for dental clinical research. Highly recommend you read that. It was published in 2013, and they mention some of the benefits that we have. I'm not going to go through them, but there's also lots of challenges as well. And so one area that I want to touch on a little bit is this issue of data quality. So we can think of data quality in three ways. One of them is the completeness of the data. Do we actually have the whole story of the patient there? In our very fragmented healthcare system, we probably don't. we probably don't have all the information about that patient's dental care or medical care, for instance. We just have this kind of view that we get from the patient, when they come into our clinic. Obviously, there's incomplete missing data, which might be due to the way we collect information, which is a challenge. So there's all this issue of completeness. Then there's the issue of accuracy. How accurate are the data? So if we're doing a really nice prospective registry, for instance, we can collect really clean data. Everybody's calibrated. They're doing it the same way, asking the same questions. We're at the granularity we want. We don't necessarily have that in electronic health record data. So that's a potential challenge as well. And then we have inconsistencies as well. Or, how consistent are we, especially when we're looking at multi-institutional data? We all do things differently. Obviously, there are similarities, but the perspective we take, the context, all of these things are really important to understand when we're doing a research project. So, data quality, is a persistent challenge. There's no one answer. I can't tell you BigMouth, is definitely a high-quality data set. Our advice is when you're doing research, you obviously have to take these into account when you're analyzing the data and making your interpretations. Okay, so now I want to actually demonstrate BigMouth really quickly. So BigMouth, we were lucky because we didn't develop the infrastructure for BigMouth. We were able to take advantage of the I2B2 data warehousing framework, which was funded by the NIH, and I think was developed by Partners Healthcare over in Boston. And they've made available this whole data warehousing platform for everyone, including many academic medical centers who adopt it. One thing that was very appealing for us was they actually had a web interface that you could actually use where users can kind of drag and drop and query things. And so that was really exciting. So obviously, all the sites use Axiom, which many of you are familiar with. I know UT San Antonio here, and many of your schools probably use Axiom. And then we also relied on this thing called the In Common Federation, which is a service provided by Internet2, which is really great for authentication, because again, we wanted to have all of these users from contributing sites log into this using their own credentials and being able to query and access BigMouth. So now I'm going to go to the demonstrations. So let's see if this actually works. So you can't actually see my screen. Is there a way, Annalise, that you could see the web browser on here? I have to mirror it.
That's one way to do it.
Okay.
That's the best way, but.
Okay, we can try that. So I'm going to try and look over there while I type. So I can't see it on my screen, so bear with me here. So this is the BigMouth website. So you've got bigmouth.uth.edu, that's the website address. And this is what people actually do when they have access to BigMouth. So what I'm going to do is I'm going to log in. And when I log in, this is going to be a bit of a challenge for me. So I'm going to log in using my credentials at UT. Okay, then it comes to a page where I'm supposed to put in my username and password. So I'm going to do that. And so if you're at San Antonio, for instance, you'd get to your page, whatever that looks like, because most of the academic medical centers are in Commons Federation. So I'm going to log in. Hopefully it'll take my password. It's authorized me to access, and I'm going to click Launch. And when I launch, this is when I get to the BigMouth interface in I2B2. I'm the administrator, so I have access to the whole thing. But if I'm a user, for instance, from UTH, I click on the UTH, and what would happen is, I'm going to click on Corey just so you get the full view. You will actually be able to see two folders here, Axiom and Corey. I think I'm going to have to make this a bit bigger because I didn't see it on the screen. There you go. Okay, so you can see here, under the Axiom folder, there are these various other folders. So I'm going to just pick on UTHealth. This is here at Houston. And it gives you some numbers here. And the numbers here are around 327,000. This is the number of patients we're getting from each of the systems. So you can see, at UT we have this many. These are the number of patients at some of these other sites. So there's two ways a user can look at this. They can look at an individual site, only their own. So they can only see their own. So at Houston, our researchers can only see UTHealth, or they can look across our network. And this, we call it CORI because this is our consortium that I'll touch on later, Consortium for Oral Health Research and Informatics, which our users are working through. And so what I can also do is search across the network. So let's say I wanted to do a query at UT, and I wanted to find the number of patients who have some sort of chronic periodontal disease. As I mentioned, many of our sites, including UT at Houston, we actually collect diagnosis information, and we've been doing that since 2011. So we have quite a lot of data. I think it says around 56,000 patients over there, where we actually have diagnosis information on there. So I'm going to make this a little bit bigger so you can see it. So I'm going to go down the tree here, and this is the organization of the diagnostic terminology. And again, I'll touch on that in a second. So this is the periodontics tab, and you can see, I think it says 16,000 patients. And I'm going to look at the chronic periodontitis subfolder. And we've got about 9,000 patients with a chronic periodontitis diagnosis, and I can pick a specific one like generalized moderate chronic, where we have 3,000, but I'll just click the folder. It's simple as dragging it across. And here I can do a query. I can say how many patients, and I know here that there's about 9,000, how many patients have chronic periodontitis and something else? So, we all are interested, for instance, in diabetes, the relationship between diabetes and some sort of periodontal disease. So what we can do is we can actually go to our forms at UTH. So we all collect a medical history, and we do it in our comprehensive medical history. And when you open up this active forms, you'll actually see there's going to be a whole host of forms. And this was the amazing thing to me. We have all these forms at UT where we're collecting information in very disparate ways, which sometimes, again, is a challenge. Our GPR program have their own forms. These other residency programs have their own forms because they all have their own information needs. But anyway, I'm going to go down to the medical dental history here, full. I'm going to open that up. So we have both a dental history and a medical history. And our medical history is really long. It's about 200-300 questions. And I'm going to go all the way down. And this is laid out in the same way that it's laid out in Axiom when our users actually see it. And maybe somebody can help me. Once you see endocrine, let me know. So we've gone through the respiratory. Here we go, there's endocrine. So these are endocrine things, and we've got this question about diabetes, where we've asked the question to about 44,000 patients, and this tells us the number of patients who have said no, they don't have. And again, this is self-reported data. So again, thinking about the accuracy of this. So I'm going to drag this concept, and I think it says about 5,000 patients diabetes, and I just drag it into the second box. If you do queries across boxes, it's like an AND. Like Boolean logic. If you're going to do it in a box, it's like an OR. So I'm going to hit run query. And then it asks me, what do you want? I want to know the number of patients. I can also look at the gender patient breakdown if I want. And I can also look at the race patient breakdown if I want. And so then it's going to go back onto the servers at UT, and it's going to query the database to try and give me a count of the number of patients that work. Now let's see if this actually works. I often remember at these times, Bill Gates, where it crashes for him whenever he used to demonstrate Windows. It never happened to Steve Jobs for some reason. Okay, so these are the number of patients that we have that have both, some sort of chronic periodontitis and diabetes. 1,313. You can see the female-male breakdown, and you can also see kind of the race breakdown as well. And there's different ways of visualizing this, to make it easier for somebody to look through. So this is a tool that our researchers can actually use, and they can get pretty complex with it. Just using all the data here, and you can also sequence things. You can say, okay, I want to have chronic periodontitis occur first, and then a diagnosis of diabetes, or something like that. So that's the way I2B2 works, and I just want to show you the types of data that we have. So we've got demographic data, we've got diagnosis, we went through the forms, we have insurance information, we have information on the tooth chart, periodontal chart, and the way the periodontal chart, because it's so complex, what it tells you is how many patients do we actually have some data on these variables, such as bleeding on probe ring, or plaque, etc. You can't yet search the levels of these because of the multidimensionality of the data. We're working on that, but that's what we have so far. You could look at different practices that we have at UT. Interestingly, you can look at all the prescription medications that we have, and obviously the CDT procedures, which we do really well on in terms of collecting, and then also the providers. So that's what a researcher can do at one site. Then they can also look across the network. So they could do that same query. I'm not going to do it because of the sake of time, but essentially, they could look at the diagnosis tree, and you can see we've got about 240,000 patients with a diagnosis across the network, just from the 6 sites, and some of the sites don't yet use diagnosis. And then they can, similarly look at forms. And so a lot of the work that we have to do at UT, because we don't have standardization, is we have to put the data together. We don't all use the standardized way of collecting medical history data, so we have to have somebody manually go through and map these data, which is obviously really time-consuming and complex. So that is BigMouth in a nutshell. So I'm going to now move back to the slideshow. Okay, so this is kind of a summary of how much data we have. We have data on about 2.1 million patients. Now that sounds a lot, and the reason why it's quite a lot is we import everything that an institution has in their electronic health record. At UTHealth, for instance, we imported a lot of data when we adopted Axiom 10 years ago, so we have all of that information, whatever we had. We obviously didn't have the diagnosis, we didn't have the medical history information, but we do have some demographic information, for instance. So this kind of gives you a range of things. But again, we have things like diagnosis information on a few 100,000 patients, for instance. Okay, so what can you actually do with this? So this is just a very simple schematic where we plotted the zip code distribution, geographically, just across these 6 sites. And you can see, different colors represent the different institutions, that, we're covering, a significant amount of the geographic area. Obviously, it may not be a representative sample of the population, but it does show some breadth of data that we have. The thing that we've been working on, and with special thanks to NIDCR, who've really prompted us to look into this, is, okay, it's all very nice that you have dental data, but what about the medical data? And so at UTHealth, for instance, at Houston, we have a large ambulatory care practice called UT Physicians. And so what we've done, actually our team, our informatics team at UTHealth has done, is they've developed a master patient index, which basically matches patients from both systems, using things like their name, gender, date of birth, race, ethnicity, etc. And so what we've found by doing that is, in our Allscripts system, which is the EHR medical practice uses, we have about 1.2 million patients. When we look at our Axiom system, where we have about 300,000 patients, we've been looking at the overlap between just those 2 systems, and the overlap is, we think, about 44,000 patients. So we have 44,000 patients where we have data from both the medical side of the house as well as the dental, because obviously not everybody in our dental clinics seeks their care through our UT physicians. They may seek care elsewhere. So obviously, in terms of completeness, we're not doing too well. But at least we have 44,000 patients where we can look a little bit further on. I didn't want to do a demo of this, just again because of time, but we've actually now incorporated this within our interface. So this is the first time that I'm showing this, and what you can see is before you had Axiom query. Now what our UT Health people can do is they can start querying our UT physicians data for those 44,000 patients who are shared. So I just did, and we have information on the patient's diagnosis using ICD-9. The team is working on bringing ICD-10. And then we have things like their immunization, medications, problems, procedures, etc. All the other structured data that's easier to gather in the medical record. So just a quick query that I did. How many of those 44,000 patients actually have diabetes? And this was the number using the ICD codes. So now we're not relying on self-reported data. We're perhaps relying on some more clinical type of data. And obviously we could start looking at lab values and other kind of phenotypes as well. So that's BigMouth in general. That's how people access at the first level this data set. Talk very briefly about data governance. So this was our initial data governance plan that we used. One is obviously, we have to be really responsible. This is a centralized repository at UTHealth. We need to adhere to the privacy and security requirements. Number 2 was very interesting, where we said access is provided only to those institutions who contribute. So if Gary Guest wanted to get access to the repository, he would not be able to until UT San Antonio started contributing to the data set. So that was one of our principles. And that was, again, to encourage people to do that. Number 3 was each site retains kind of control of their contributed data. It's not ours at UTHealth. If somebody wanted to remove their data, they can do that at any time. It's, they're responsible for that data in terms of how it's used. Number 4 is, any of our users can actually do the things that I just showed you, but in order to actually get access to the data, those 3,000 diabetic patients, you actually had to go through a project review committee as part of our consortium, which has membership from each of the contributing institutions, submit your project requests, and that committee will approve it. Excuse me, and only then would we be able to release the data to the site. And obviously they need to have their own local IRB approval as well. And then number 5, this issue of data quality, where we have to be really conscious of this and try to improve it. We've actually come up with a new data governance plan, which we're in the process of implementing. Again, based on a lot of the feedback from our users, we get requests from people who aren't contributing researchers who want access to the data. So we're working on our data use agreements to open this up now as we speak. Excuse me. So our legal officers have told us we're allowed to provide access to a de-identified set of data from BigMouth to anybody from a non-profit institution. They're not quite ready for us to provide it to some sort of commercial source at this point. So, for instance, now if Gary Guest wanted to get data, he may be able to do that in the future. Okay, so how do you access BigMouth? We've got 2 levels of access. If you are from one of these sites, you basically sign in. There's a process where we verify your identity. You then go in and log in. You can then have level 1 access, which is to explore the BigMouth database. Level 2 is what I talked about, where you actually have to submit your proposal to this research review committee. And then you'll actually receive the data set for analysis. So how do you become a contributing institution? We're working within the framework of CORI. There's no cost to join the Consortium of Oral Health Research Informatics. You can become a member, excuse me, and then you have to complete a data use agreement and get IRB approval. Excuse me, I'm fighting a cold right now. So this is CORI. So CORI, how many of you are familiar with CORI? Okay, good, because many of you should actually be members, or your institutions are probably members of CORI. And the main message here is we want to standardize things. We heard a little bit about the benefits of standardization. We're all doing similar things in our dental institutions, especially academic dental institutions. So why are we doing things so many different ways? So let's try and standardize various things. And so that's kind of the mission and vision. I think as of last year, this is the number of members that we have. And these are the resources that we have available. So through CORI, we've actually standardized the medical and dental histories for both adults and pediatrics. We have a standardized problem list. The Dental Diagnostic System that was led by Elizabeth Calendarian, then at Harvard, came out of this group. And then we also have a caries risk assessment, and the BigMouth Dental Data Repository obviously came out of this group as well. So just briefly about diagnosis. So again, to try and answer that question on why don't we have diagnosis in dentistry? I think we actually do, and I think Dave Preble is here from the American Dental Association. And so from the academic side, since about, I think, 2008, 2009, the academic side thought that there was no diagnostic terminology that was easily usable within the interface of Axiom. So a group of academics through CORI got together, led by Elizabeth, and formed the Dental Diagnostic System. And the idea was that we wanted to make it easy for users to actually pick these terms. We followed the principles of Dr. Semino, who will be talking later, regarding how do you develop a good terminology. And we implemented it. And a lot of the data that I showed you in BigMouth actually comes from the Dental Diagnostic System. Over the last few years, that has now evolved. And we've actually been working with the American Dental Association, who had already developed the SNODENT terminology as well. And so what we've done with the American Dental Association is harmonize the terminology, especially at the level of what we're calling SNO-DDS. And so this is that interface terminology with about 1,500 different concepts that we think are granular enough that dental providers, especially dental academics, want their students to know about. And so that's a terminology that is available. And that all sits within SNODENT. Now, SNODENT is a ontology that not only has diagnosis information, but it also has other information as well, really nicely related in an ontology fashion, so it can become computable. So people who want to take a concept in SNO-DDS and relate that to some sort of anatomical relationship can now actually use SNODENT and the relationships within SNODENT, which is now part of SNOMED as well, to do all of these things. So we've got this really nice consistency from it, all the way from the interface all the way to kind of really robust reference terminologies that can be computable. In addition to that, what Dave has been leading is this development of the SNOW-DDS GD, General Dentistry. So this is a smaller subset of SNOW-DDS that we think that dental providers out in practice, so they don't have to go through 1,500 terms, they may not want the specificity, they can actually use this general dentistry terminology as well. All this is now ANSI approved standard as of, I think, last year, Dave, right? The end of last year. So this is actually a standard now and, can be used by all institutions. So we do have a diagnostic terminology, and the important thing, there's one of them. Okay, so some examples of research projects that have actually used BigMouth. So one example that's pertinent to diagnosis is one that Elspeth led regarding the value of using a dental diagnostic terminology in an EHR. This was published recently, and basically what she was looking at is, what kind of treatments are patients getting who have a diagnosis of chronic moderate periodontitis, and does this follow the AAP guidelines? I'm not a dentist, so I won't go into this, but what we can do from BigMouth is to actually see what kind of treatments people are getting, which may or may not surprise the people who are giving them. So this was a nice way of framing how we can use BigMouth and the dental diagnostic terminology to do something very simple. Interestingly, we had a whole bunch of people who weren't actually getting any treatment despite having this condition. Some of our residents have also started to use BigMouth. So this was one of our residents who graduated, and he was actually looking at the accuracy of periodontal diagnoses dependent on the teaching model, whether it's a generalist and a specialist teaching model, which was interesting. We've also had a researcher look at partial mouth. So this was a PhD student in public health, a dentist, who tried to develop a better algorithm for partial mouth examination, and he used both the NHANES data as well as data in BigMouth to try and develop a better partial mouth screening process. Interestingly, when it went to publication, the reviewers had a big hang-up with the BigMouth data, and they thought the NHANES data was obviously very good. So we actually had to remove the BigMouth data because of that hang-up, which I thought was interesting. And I hope that groups like this may help to change the culture, to help better understand some of the benefits as well as some of the challenges of using EHR data. We've also have the same researcher looking at these associations which we can do between obesity and periodontitis, and he's actually also looking at the medical data. So this will be one of those studies that not only is looking at the dental data, but some of the medical data that I showed you as well. We have had some residents from our endodontic department look at statin use and how it may be correlated with various types of endodontic diagnoses. And then most recently, an article was published in JDE about TMD and how students were diagnosing these. And basically what was found is very little diagnosis by students on TMD, and that's probably a curricular type of issue. So those are some of the studies that have been done. I want to touch just very briefly on quality measures, because again, we're trying to go from data now to information. So we're fortunate to be funded by NIDCR to actually look at dental quality measures in practice. And this is a study between 4 different institutions, UT, Harvard, UCSF, and the Willamette Dental Group, where we wanted to define quality measures that can be run through electronic health record data, and then have a larger group of institutions actually adopt them and also provide kind of these meaningful dashboards for them. So this is just a definition of quality in terms of how the IOM defines quality. You're all familiar with quality measures. There are different types of things that we can measure when it comes to quality. Obviously, the holy grail is to measure health outcomes, but a lot of the work is actually being done regarding process, which is what kind of stuff are we doing to patients. We're hoping that correlates to actual good outcomes for patients. So that's also what we've been focusing on here as well. So again, this just goes through some of that. In addition to process and outcomes, we can also look at access measures or structural measures or even patient satisfaction. So all of these things are part of when we're thinking about healthcare quality. So these are the 10 quality measures our team has been focused on. Diabetes and annual kind of periodontal evaluation is the first one that I'll give you an example on. But obviously we're looking at the ones that are available, such as sealants, tobacco screening. We've also now starting to look at what percentage of our patients actually have a caries risk status on file, because we think that's important. If they have a caries risk status, what kind of preventative treatment are they getting? Measure 5. And then we want to look at caries outcome in terms of their change in DMFT increment as well. Similarly, we're developing measures for periodontal risk. How can we define periodontal risk? Based on their risk, what kind of treatments are they getting, and then what are their periodontal outcomes? And then lastly, we're looking at, what kind of care do our patients who are pregnant actually receive? And interestingly, what we're finding is we see very few patients who are actually pregnant, unfortunately, at dental schools. Okay, so this is an example of one measure that I just want to go through briefly. So when you think about a quality measure, normally you have a denominator and you have a numerator. Denominator is the population that we're interested in. So in our case, these are patients who report having diabetes according to that self-reported data that I show you. And the numerator is basically how many of those actually receive some sort of oral evaluation. And again, the intent is periodontal evaluation, but if they received a comprehensive exam or some sort of periodontal exam, we'll give them credit. And this all comes from the work from the Dental Quality Alliance, which has done this really nice work in terms of specifying these measures. The DQA focuses their work on claims-based data, although they have moved some measures to EHR. So what we're doing in our work is taking claims-based measures, if available, and we're trying to adapt them for use in the electronic health record. And I'll demonstrate why that might be useful. So based on this calculation, we can then figure out how many of our diabetics actually receive care, and that's the measure score. And we've developed this whole kind of approach for how you validate the data. How can you verify the completeness and the accuracy of this data in the EHR? And we've published about this, and you'll see kind of papers on this hopefully soon. So I won't go into that. But when we ran this measure, this is what we found. When we think about this, when we verify something, we can actually do manual chart reviews where we have two people, dentists go into the record and say, is this true or not? Compared to what our computer algorithm, our automated query can find. Because obviously we want to create a measure that we can automatically pick up from the EHR. So when we did this, we found that our automated measure, our query that we developed through these sites, 4 sites, we found the measure score, 71% of our patients in total got these periodontal evaluations. But when chart reviewers actually went into this, they found actually it was a little bit lower than that. So it was kind of overestimating that number. And here we can then calculate various things like the sensitivity and specificity of the measure, et cetera. And this just basically shows that we did 1,200 chart reviews, and there are about 13,000 automated charts in there as well. We then tried to figure out what happened in all these cases. Why were certain people not getting the care received? Why was there an error in the script, et cetera? What we found was interesting. So based on the work that was done on claims-based data, we were finding that many patients may not have been excluded who probably should have been excluded. So they may have been miscoded, they may have been discontinued, patients may have no teeth, and from our clinician's perspective, we were saying, for this measure, having teeth was not, should be an exclusion factor if you want to have a periodontal exam. Or they may have just come in just for a one-time emergency visit, so should people be held accountable for that or not? And then what we found when we looked into this, people are actually getting other acceptable periodontal care as well that we think should be part of this measure. They're getting prophylaxis, maintenance, full mouth debridement, scaling and root planing. They had a full periodontal chart completed. So that obviously you don't have in claims-based data. So we can now start looking at all of this in an electronic health record context. So we adapted the measure, and this is just kind of the algorithm for this. We recalculated the score went up to about 83%, and we were able to get really good performance between the manual and the automated query, so we can say, okay, we're pretty sure that the automated query performs just as well as if a manual chart reviewer were to do it. And this gives you kind of some of the statistics based on that as well. So that was good, and we're using that same process for the other 9 measures as well. So the next step that we are working on right now is, okay, it's all fine and good that we're doing this, but so what? How can we actually feed this information back to our clinical people, whether it's an administrator or the clinician or the student or whoever it is, or at the policy level? And so these are just some dashboards that we're beginning to prototype. And again, we're using this kind of participatory design process in terms of trying to find out what is useful rather than having our requirements all up front. Okay, so just in closing, in terms of the next steps for BigMouth. So obviously we're concerned, or we're interested in scalability. We'd love for, there are about 40 institutions who are part of CORI. We'd love for all 40 of those to actually be contributing, but is that scalable in a centralized data repository? Maybe, but maybe not. Maybe there are other ways. So we're looking at other kind of frameworks for that. Number 2 is standardization. We spend a lot of our time mapping data together, oftentimes manually. We're trying to automate that, but without standardization, at least in the content, in terms of what we're collecting, it becomes pretty hard. Number 3 is sustainability. This is pretty expensive stuff. Not as expensive as running randomized controlled trials, but is expensive. So we've put in a financial sustainability plan where we have cost recovery fees for those institutions who want to contribute. We have annual maintenance fees, and then we have data extraction fees to cover kind of programming time to get the data out once you go beyond that web interface. Number 4, which is really exciting to us, is linking to the medical data itself. So we're now beginning to do that at one site. We're hoping, once we can get it working at one site, we're going to be able to convince the other institutions, again, some of this is a political issue, not a technical issue, that they should also contribute their medical data for the common good, at least the overlapping data that we have as well. And then lastly, obviously with all of this precision medicine focus, it would be really good for us to now look at not just this phenotypic data, but also the genomic data, and can we actually link some of our patient data to some of the studies that we're already doing at our institutions by some of our researchers. So I do want to acknowledge the BigMouth team. This isn't just done by us at UT Houston. We have collaborators at UCSF, Harvard, Tufts, University of Pittsburgh, and University of Michigan. Also want to thank our dental quality measure team that's co-led with Dr. Elsbeth Kalandarian. We have Dr. Newman here from UTHealth, who's participating, who's our Director of Dental Public Health. So thank you to all that group, and obviously to our funding agencies, both the NLM and NIDCR, which we could not do any of this without. So thank you for your attention. I'm happy if there's time to take any questions.
Thank you, Muhammad. I haven't seen this project in a while, and two things. First, I wanted to commend you for, you else, but everybody. I remember when this was starting to happen years ago, and now I'm seeing it again, and now you are actually giving a demo for in data. I hope people realize that if you're seeing it for the first time, that this is a lot of hard work. Not only technically speaking, but also politically, socially, having all these pieces together, all these organizations coming together and actually getting hands-on, building things, connecting, takes a lot of work, and finally it's coming, is realizing, finally now public health, dental public health has the opportunity to start, starting to play with the big players, right? Finally the value of data is going to start showing up. I represent CDC, and we usually have had that sort of that role, but we're usually the only ones, right? And NIH also. We're not the only ones, but usually it will be the sort of the federal government, to some extent the state and local. But that was it. Now all of a sudden, now here comes what I think the real promise of that, and I'm excited to see it finally happening. So it's great. I think it's very important. We all recognize that. So the other thing I wanted to ask you, I saw the next steps, points that you sort of vision. I also wanted to, in that sense, I also want to ask you, is there any sort of big picture down the road, or maybe genomic and medical? It's kind of there, but everybody's doing that. Have you thought of other things that maybe you should looking at? And let me give you an example of what maybe you should be thinking about. Things like you're talking about a lapse of 6 months, right? There's data upload and they're processing and whatever, and then you gotta wait 6 months, and then 6 months is sort of a significant period where things may actually change population-wise. That's the thing, we don't really know. Usually papers get published based on 2-year-old, 3-year-old data, compared to having a real-time approach. So I don't know if, maybe down the road that's sort of the way. I know these are technical challenges, but those can also be solved. So I don't know if you have given some thought of sort of more of a bigger picture 10 years down the line, or maybe 5 years down the line, where you really be, transforming the way we can do research.
Yeah, no, absolutely. I think we've thought a lot about how current the information should be. So as you mentioned, it can definitely be done, on a real-time basis, with technical resources and the will and things like that. I think what's more important is it would be interesting for us to get people to use the repository so that we can better understand what's needed. And so if there's a researcher that comes to us and they say, we really need real-time data for this specific research project, we can design it in a way that we can do that. So how I would rather us having a global vision or a long-term vision for this, I think it's more of a community vision that we have to develop. And that's why I really love this new organization that's being formed, because I think these are the types of organizations that can contribute to the vision. We can design whatever, as was mentioned earlier, but it may not mean technically the use in reality from a clinical perspective. So I've been a little bit hesitant to try and be too visionary and long-term without kind of understanding what this community wants. Because to be frank, I'd expect more usage from this repository.
We have one question on this.
Thank you very much for your presentation. I was hoping that you could speak a little bit in terms of next steps with clinical decision support. I know that Willamette is sort of, a leader in that area, and I know that there's sort of a rudimentary component to Axiom. You diagnose something and it can lead you to a certain form. But if you could talk about how that is either currently being used or how you foresee that in the future, please.
Yes. So good question. I think decision support can be done in different ways. So one of the areas that we've been thinking about, along with my colleague Heiko Spalek, is kind of this idea of audit and feedback information, getting data back to the provider, which may not be directly in the health record, it may come outside of the health record. So one idea that we're exploring right now is some of the patient-reported data, and we're thinking about pain, patient's pain level after procedures. What happens if we can feed that data back to the dental provider? What will that do? How will that impact their decision-making as well? So that's one area that we can do. We've been thinking a lot about decision support for BigMouth. So even though the data may be 6 months old, from a clinic administration perspective, who are looking at data not daily, but maybe quarterly or yearly, some of these data they don't know about because it's often difficult to mine data out of Axiom in a standardized way. So this might be a repository if we can come up with kind of these consensus reports that we can run, like we're going to try and do with the dental quality measure dashboards. So imagine you've got these 10 dashboards, you're an individual site, you get to know how well you're doing, and perhaps you can also see how well others are doing as well, and that was going to start sparking a conversation about, what can we all do better. So that's that type of decision support. But I think what you're talking about is decision support at the individual clinical provider level. And I know a lot of work has been done, especially in medicine regarding decision support. It was always seen as this really great thing that's going to change behavior and greatly improve outcomes. I think in the medical side, there's been a lot of disappointment about decision support. Maybe it's because of the design and how frequently these kind of things pop up and frustrate users and all of that. So I think the more innovative work is not going to be on these like pop-ups and very simple things that we can do, but more on really understanding from a cognitive perspective what the dental care provider or the healthcare team is trying to do, and then trying to anticipate some of the information that they may need. And so we often think of decision support as alerts. I think we're going to have to get away from that and think in different ways.
Dr. Walji, will you be available later for any questions
Yes.
offline?
Yeah,
Okay,
absolutely.
so I think we'll end questions for now. But
And on the handout, my email address is incorrect, so you'll have to you can use this email address to contact me. Yeah. Do we have time for another question? Okay.
Yeah, thank you for what was a very informative presentation. You quickly mentioned, but somewhat glossed over, the cost implications. I was just curious as to what the cost implications are for dental schools that would be participating.
Yeah, so for new sites who want to participate, we have a $10,000 fee for them to join. And that basically is a setup fee that we work with their team in order to get the data out and model it into BigMouth. So that's the $10,000 annual fee, one-time fee, and then we have a $2,500 maintenance fee that we would charge subsequently every year. And that would include the 2-year things. And what we're trying to do is just fully cost recovery. So we talked to our institution and we said, this is the minimum amount of just programming effort, technical effort. Doesn't include any of my time, just our programming time in order to do this. We cover, subsidize all the hardware costs and all of that. Okay, thank you.
Thank you.